Hello, and welcome to today's webinar, The Power of Direct Observation, Answering Residents' Most Asked Questions. This is our 13th and final installment of this webinar series focused on navigating the shift to competency-based medical education, brought to you by STFM and the AFMRD with support from the ABFM Foundation. We hope you found this webinar series to be a helpful addition to the CBME toolkit. You can access this recording as well as the rest of the series at stfm.org/cbme webinars. During this webinar, please utilize the Q&A feature to ask questions of the panelists. Although you may ask questions at any time, designated time has been set aside to answer your questions toward the end of the presentation. Today's panelists are Dr. Maggie Curran and Dr. Jenna Kay. Dr. Curran served the STFM CBME task force as a resident and is now an assistant professor at the University of Kansas Medical Center. Dr. Jenna Kay is a third-year resident at Colorado Plateau Family and Community Medicine Residency who also served the task force. And now Dr. Curran will begin today's presentation.
Great. Thank you, Jenny. And thank you all for joining us both live and those watching after the fact. We're excited to get to talk to you today about direct observation and particularly focusing on that resident perspective. So starting out, we like to review our goals for our session today. Our two main objectives are being able to describe the role direct observation plays in helping residents advance to the goal of autonomous practice, and then how to use feedback and the assessment data they receive from direct observation in order to tailor resident education to their future goals that they have identified for themselves. A quick thank you to the residents that have helped develop this presentation today. All of the residents you see here are residents at programs participating in our direct observation pilot program put on by the CBME task force. And so they are our boots on the ground look at exactly what's going on with the implementation of this direct observation assessment and tools. And so we were able to participate in a focus group with the four of them to really guide the content of this presentation. So I'm very grateful for their time and their already busy schedules. So starting out, I always like to set the stage with the why. Why does direct observation matter, and why is it such a key pillar of competency-based medical education? So the first pillar of this is really that it mitigates bias and it avoids assumptions. We know when we're doing our indirect observation methods, we're getting presentations from our residents. There's a healthy amount of assumption that goes on with exactly what happened within the patient room. We know that we don't get to see that physical exam. We don't get to view the conversation. And so by doing direct observation, we're removing that assumption. We really get to see exactly what's going on. And because of that, apply really specific feedback for the resident. We also know that it's more reliable because we're getting more data points. We're getting data from multiple settings of practice, multiple observations in those settings, and from multiple observers. And so it removes the outliers of maybe somebody who's had an awkward patient encounter or just is having a bad day. And we can really identify those trends in resident progression of their practice early on in their residency and continuing on during their training. And because we're identifying those trends, it leads to opportunities for improvement earlier on. We're not waiting for that summative evaluation that comes at the end of a rotation 4 weeks or 8 weeks after the event. We're getting that feedback in the moment right then and there that allows us to hopefully show progression and improvement over that rotation rather than waiting until the end. And because of that, we know that effective feedback in the moment is going to be a really important piece of this puzzle, because we know if we can get that feedback immediately after the observed encounter, that resident can take the feedback that they've received, take it directly to their next patient encounter and the rest of their clinic session to make strides in their education rather than having to wait for that feedback to come in the future. Starting out with the benefits. So there were some key benefits that the residents that I spoke with identified as as part of participating in direct observation. And so I think a really obvious one is procedural guidance when it comes to direct observation. This is a piece that is already integrated into our training programs. We know that attendings have to be present when it comes to precepting procedures. And so this guidance when it comes to graduated autonomy, watching them progress to being able to do these procedures independently feels really natural and is a really good example of why direct observation is important. The residents also aptly identified that this can apply to physical exam skills as well. When it comes to primary care, we do a lot of specialized examinations, whether it be MSK exams like the shoulder exam with all of our special testing, neurologic exams, for example. And so when we're getting those just presentations from residents, we're kind of making an assumption that those were done correctly or those were done in a way that made the patient feel comfortable. And so by directly observing those skills, we can provide feedback not only, was that examination done correctly, but how can we help that flow better? How can we make the patient more comfortable with that experience? Like I touched on earlier, we're getting more data points. And so we're identifying those trends and we're not relying on these summative examinations to really determine how our evaluations go and how kind of our program's opinion of our residents. And so we're able to show growth earlier on, both in a rotation, but over the course of residency as well, each PGY year and as a whole. And so we can act on trends that we're seeing sooner, whether they be positive or potentially negative, and try to alter those as we can. Potentially most importantly, we know that direct observation allows for holistic evaluation. So indirect observation is really well suited to evaluating things such as medical knowledge, developing plans, integration within the health system with things like medical referrals. But it doesn't do a great job necessarily of identifying things like communication skills, agenda setting, building rapport with patients, because we're making a lot of those assumptions from indirect observation. And so we know all of those characteristics, along with medical knowledge, make good and adequate family physicians. And so we want to make sure we're providing observations for those skills as well. Our residents have also identified that this has improved feedback quality because it really is individualized and it really is directly applicable to areas that they've identified as personal growth. And so the faculty that have really dug into this experience and taken a really healthy role in this process have learned exactly what the residents are looking for when it comes to feedback. And the residents can have those conversations with faculty as well when it comes for directly asking for what they are hoping to improve on, and letting faculty know what feedback has been most helpful and what maybe could make their feedback more applicable to their learning. And then we'll kind of walk through this process later on in this webinar, but we know that direct observation assessment tools really do get to guide individualized learning. The root of competency-based medical education and direct observation as a piece of that is that we can use those, the feedback we're getting to guide our individualized learning plans and guide exactly what we're trying to get out of direct observation. With anything brand new, we know that there are going to be roadblocks. And so I will not claim that the five of us have come up with solutions to any of these things, but I do think there's a benefit in identifying these roadblocks so that there can be brainstorming and conversation about what may be able to help us tackle these. With anything brand new, we know that buy-in is going to be a roadblock that we need to try to maneuver. And so I think this is less so for our first year residents because this is something that they joined residency and we're already, joining this from day one. And so they can really start to see the utility from it right away. This tends to be more of a concern brought up by our second and our third year residents because it is something brand new that we're asking them to do that's different than what was going on in their education previously. And so sometimes it can feel like a step back when it comes to their autonomy as they're moving through residency. So some thoughts and suggestions that came up from these conversations with our residents was that making sure we're tailoring our feedback from direct observation to where the resident is in their learning, recognizing that there are some things that are probably really ingrained in our third year residents by the time they're nearing the end of residency that we may not be able to adjust if it comes to how they maneuver a clinic visit, for example. But there are a lot of things that are still really helpful to give direct observation feedback on, things like efficiency within their clinic, managing a busy clinic day, agenda setting, those types of things. And so making sure we're tailoring this experience to where the residents are and not making it a one size fits all experience. Duplicity of feedback leads to a lot of feedback feedback fatigue. And so we will touch on this in more detail later on. But one thing that we've noticed is that in our programs that are participating in the direct observation pilot, there's a specific direct observation assessment form that's being utilized. But oftentimes faculty are being asked to use the original or kind of routine feedback form for that program as well. So this leads to not only more work for the faculty member having to fill out multiple feedback forms, but more work for the resident as well, because it's more things that they're having to sift through, and it can kind of feel like it's piling on the feedback, making all of it feel a little too overwhelming to work through it and make use of. And so suggestions that were brought up were if we're participating in direct observation and utilizing that form with the faculty member, making that so that's the only feedback that form that that faculty member completes for that resident that day, knowing that they can put more time and energy into completing and making it really applicable and really concrete feedback with examples, so that they don't feel burnt out with having to fill out multiple feedback forms for the same resident for each session. And then efficiency. I think this is one that's no surprise to anybody. We know that as primary care providers, we are very busy in our clinics. We have lots of patients that need to be seen, and lots to accomplish in a clinic session. And so this can be something that feels overwhelming when trying to add in something new to the educational process in each clinic session. And so I think this is less of a problem that with our first year residents who oftentimes have longer appointment slots. Oftentimes, attendings are required to see their patients anyway for billing purposes. So it feels a little bit more natural to integrate it in those settings. And it takes a little bit more pre-planning from our second and our third year residents and the faculty working with them, so that we don't get behind and we're not delaying patient care. And so really making sure that we're doing pre-planning with faculty to plan ahead of exactly how we can integrate that into the session. Some cool opportunities that are happening at some programs are dedicated clinic sessions where there's maybe a 1-to-1 or 2-to-1 faculty to resident ratio. And that whole clinic session is based around direct observation. And so making it built into the curriculum has been really helpful for our residents and making this direct observation feel run of the mill and not something that's requires above and beyond effort or something that feels punitive. So like I mentioned, feedback fatigue is really real. And I think especially when we're integrating new feedback mechanisms, but without getting rid of the old, it can feel like a large kind of administrative burden for both parties. And so some of the suggestions that came out of this focus group are listed here. The first being making sure that our goals with direct observation are individualized and potentially even tiered based on PG postgraduate year. We know that when our first year residents come in, they are a blank slate. They have lots to learn. They have longer patient encounters. So it can be easier to get a lot of those direct observation numbers done. And there's a lot of room for them to kind of identify their goals and rooms for improvement. And then as we grow along, to kind of combat that feeling from residents that we're taking away their autonomy or we're taking away their ability to kind of practice independently or pseudo independently as they're nearing the end of their third year, making sure that we're using the trends we've identified from direct observation, and setting individualized goals. So this may mean fewer required direct observation encounters for second and third years, and even differences between among the classes as we kind of identify individualized learning goals. And so recognizing that this, again, is not a one size fits all process and really should be individualized to the resident. This does take pre-planning by both the resident and the faculty. So recognizing that the resident should be looking at their old feedback assessments, identifying areas for growth, and ideally identifying encounters from their clinic sessions or from their hospital day that would be of benefit in those areas for improvement to be observed. But the faculty can really help out with this as well. And so that this way it doesn't feel like it's the onus is all on the resident. And the faculty, whether it's just showing up 5 minutes early to be able to have those pre-planning conversations with the residents, looking ahead at maybe who is behind on their numbers and who really does need a direct observation encounter, or who maybe has a good chief complaint that is a good option for being observed. Taking on some of that burden as the faculty really helps the residents feel like that both sides are bought in just as much as the other. And then allowing for flexibility and feedback. I think this was something that was really unique to me when I was talking to the residents, that sometimes with this direct observation, it felt like faculty were feeling like they had to focus on areas for improvement and not so much on what the patient was doing well or on what the resident was doing well. And so residents would leave encounters feeling like they really really were fantastic and had this really incredible encounter with a patient. And it felt like the faculty were reaching or getting nitpicky for areas for improvement without acknowledging how stellar that encounter may have been for that resident. And so recognizing that there will be encounters where maybe there isn't a whole lot of areas for improvement, but sometimes that positive reinforcement is just as important as identifying areas for improvement. And then last but not least, we know when we're implementing anything new and asking for more from residents and more from faculty, incentives are really helpful. And so whether that's maybe an extra administrative day for residents or faculty who have completed the most direct observations, bringing in food, gift cards, whatever it may be, that really does help the buy-in when we're learning and implementing these brand new things and we're asking a lot of our residents and of our faculty. So we're going to walk through this process a little bit later. Jenna will walk us through this, but what we've kind of identified with the residents as the best way to kind of implement this direct observation feedback is listed here. So ideally, residents will be looking at all of their assessments they've received over time, identifying those areas for improvement, and then using that data to identify exactly which patient encounters would be beneficial for them to have observed. Then after that observation, they can get that direct in the moment feedback from the preceptor, hopefully take some tidbit from that they can take with them the rest of that clinic session, and then reviewing that formal written feedback after the fact through our assessment forms. In the background of both MedHub and New Innovations, we're able to tie these assessment tools to our core competencies, and we know that those then link to outcomes. And so getting that data has really been helpful for our residents to see exactly how this all links back to their ultimate goal of graduating residency. So using those outcomes that these direct observation tools link to, we can develop our individualized learning plans, rinse, repeat, and we just keep going. So we've got a poll here. I don't want to belabor this too much, but I do think it's important that we all start on the same page. So how familiar are you with the ACGME competencies? I know them and use them to help guide my individualized learning plan. I know that I am evaluated on them as a resident, but I am unsure how to use them. I have heard of them, but I do not know much else about them. And this is the first time that I'm hearing about these competencies. We'll just give everybody a second or two to handle that poll, and then we'll talk through the answers. Okay, so let's see how people are feeling about these competencies. So thankfully, it looks like the majority of us are really familiar with these core competencies and are already using them to help guide education. And you've at least heard about them and we can kind of talk through how we can use those. So just a quick review of kind of what these core competencies are as defined by ACGME. These are going to be the patient care, medical knowledge, practice-based learning and improvement, interpersonal and communication skills, professionalism, and systems-based practice. So some of these do lend themselves to be better evaluated or to be appropriately evaluated with indirect observation, particularly things like medical knowledge, potentially systems-based practice. But there are some of these core competencies that are a little more difficult without that direct observation piece. And so being able to directly observe residents allows us to provide more detailed and applicable feedback to things like professionalism, to things like communication skills, which hopefully will help them improve in those areas as well. So we know that these core competencies, the next piece of this is then linking these to outcomes. So we've got another poll asking, what do you currently know about the ABFM outcomes? I know that there are 15 and I can almost recite the first five. I know that there are 15 and I don't know much else about them, or I really don't know much about them. We'll give you a second. Okay. So again, we don't want to belabor it too much, but we'll take a peek at the results here. Okay, so looks like a lot of people know a lot about the first five of these outcomes, which makes sense because these were the ones that went into effect this past year. But then a lot of us know that they exist, but we don't know too much else about them. So I'm glad we're talking about it. So I think we're going to place the link in the chat, but this is also a QR code to our CBME toolkit that lists these core outcomes. And so these were identified by the ACGME Family Medicine Review Committee and the ABFM. And so the goal of these 15 outcomes is that program directors will be able to attest to these for each resident that is graduating, that we are meeting these outcomes. And so the first 5 were introduced last June, and then the next 5 will be introduced this upcoming June, and then the next 5 the year after that. And so the goal is that direct observation, ultimately, the feedback we receive from that, the end goal is that our residents are meeting these core outcomes for graduation. So take a peek at our toolkit that kind of gives more details about those. On the toolkit as well, there's also a link on that same page that maps our core competencies to our outcomes, which can be really helpful, as well as kind of identifying how explicitly to use that feedback link to the competencies, how that links to our outcomes. So I encourage you to take a look at that. So the goal is we've got our direct observation assessments. We've now linked those to the competencies. We see how they apply to our outcomes. And now we're going to create our individualized learning plans. And so a big piece of these ILPs is creating SMARTY goals that are linked to outcomes. And so this is an example of a resident's goal that's linked to the outcome: perform the procedures most frequently needed by patients and continuity in hospital practices. So obviously we know procedures really important from direct observation standpoint. So the resident has identified their area for growth as confidence in completing these outpatient procedures by the time of graduation. And this will be measured by being successful in completing these procedures start to finish with no to little assistance from the attending. So as we're looking at these direct observation forms, that's information that the residents can get directly from those. So a good example here. So I am now going to pass it over to Dr. Jenna Kay to kind of walk us through an example of how to use this direct observation feedback form and creating an ILP.
Hi, everyone. I'm Jenna, as Maggie was talking about. I'm one of the residents. I'm a third year. And this is my first time doing a webinar, so bear with me as I don't have the opportunity to see your beautiful faces, but will try my best to keep the flow going and offer a resident perspective of direct obs. I think the best way to go about learning is doing. So I think we have a video prepared where we're going to watch the video. It's a couple minutes long. We'll sort of observe an interaction between a resident and a patient, see maybe what could be improved. And have in the back of your mind, pay attention to the video, have in the back of your mind, how would your feedback be different if you were directly observing this interaction between the resident and the patient versus if maybe this was an indirect observation and you hadn't actually watched the history taking be done and the resident had just come back to you and sort of staffed with you. How would your feedback be different? And then we'll go about sort of what we observed and how we can tie back what needs to be improved into an ILP and what core outcomes we're evaluating. So I believe we have the video here.
Hello.
Hi, nice to see you again.
It's been a few months since we've seen each other, and I see in your chart you've been having some swelling in your legs. What have you noticed?
Well, yeah, I've had some swelling and it's really uncomfortable.
Both legs?
Yes.
When did it start?
Well, it started gradually over 3 to 4 months ago. I know I didn't have it when I last saw you, but if I did, it wasn't bothering me anything like it is now.
And when is the swelling worse? Morning, evening?
It's not so bad in the morning, but it gets worse as the day goes on, and if I'm on my feet all day, I can hardly walk.
Any changes in your breathing?
No. I get short of breath if I move around too quickly anyway.
How about shortness of breath waking you up from sleeping?
No.
And what about needing to prop yourself up on pillows to breathe at night?
I sleep on 2 pillows normally just because it's good for my back and my neck.
No chest pain or pressure?
No.
No abdominal pain?
No.
Changes in urination?
No.
How about feeling cold when others are hot?
Well, I'm warm all the time. I'm still dealing
No
with
new constipation, changes in your hair, skin, or nails?
I've got some constipation, but stool softener, milk of magnesia, they usually do the trick. What was the other thing you asked me?
Changes in your hair, skin, or nails?
Oh, no.
Any changes in your medication?
It gets worse as the day goes on, and if I'm on my feet all day, I can hardly walk.
Any changes in your breathing?
No, I get short of breath if I move around too quickly anyway.
How about shortness of breath waking you up from sleeping?
No.
And what about needing to prop yourself up on pillows to breathe at night?
I sleep on 2 pillows normally just because it's good for my back and my neck.
No chest pain or pressure?
No.
No abdominal pain?
No.
Changes in urination?
No.
How about feeling cold when others are hot?
Well, I'm warm all the time. I'm still dealing
No
with
new constipation, changes in your hair, skin, or nails?
I've got some constipation, but school softener, milk of magnesia, they usually do the trick. What was the other thing you asked me?
Changes in your hair, skin, or nails?
Oh, no.
Any changes in your medications?
Well, you changed my insulin the last time I saw you.
Looks like you're on metformin, 1,000 milligrams twice a day, glargine, 26 units at night, aspirin insulin, 4 units at breakfast, 6 at lunch, 6 at dinner, hydrochlorothiazide, lisinopril, amlodipine, pravastatin, omeprazole is needed, and ibuprofen is needed. How often do you take the ibuprofen?
Well, lately my back's been bothering me more, so I've been taking it about twice a day.
Looks like we increased your amlodipine dose about 6 months ago.
Yeah, you mentioned you felt like my pressure was too high.
Right. Anything you've tried to help with the swelling in the legs, like keeping them up?
No.
Are you using a lot of salt?
No, you talked to me about that, so, and you gave me that list of foods to avoid, and so I've been avoiding those foods. Every once in a while I do cheat.
Any tobacco use?
No.
And I ask everyone this, how often do you drink alcohol?
On occasion, special occasions, birthday or anniversary. You know, about my legs, it starts like right down here, and then it goes all the way up in here. And there are times when my legs get so swollen, they feel achy, and they get tight. With the weight, the diabetes, the pressure, my back, all of this, it just feels like I'm falling apart. Nothing's getting better. And I'm taking all this medication. I just wish I could feel better.
Well, unfortunately, some of this comes with age and lifestyle. So let's see if we can figure out this swelling.
But you mentioned chest pain. Do you think I might have a heart problem?
Well, anyone in your family have heart problems?
Well, yes.
Oh, I see. Your mom had some heart disease. I think we're just going to have to wait and see. I'll still have to examine you and we'll run some tests. I also wanted to follow up on your diabetes. Last time I saw you, we increased your glargine insulin to 26 units at night, and you were going to increase the insulin before each meal to 4 units before breakfast, 6 before lunch, and 6 before dinner. Have you been checking your sugars?
Yeah, sometimes.
Can I see your log?
I forgot the log. I left it home on the counter. But I do, check my blood sugar, and so I get early in the day, it's maybe 120, 130, sometimes 150, and then it gets a little higher later in the day, like 180, maybe 203 or 230. During around, I guess, and then at lunchtime it's around 180 also.
Any lows?
No,
And your diet?
it's about the same. I rarely have breakfast, maybe a slice of toast, and then I have my lunch for dinner and dinner.
And what about dinner?
Well, my husband and I have dinner together, and we usually have chicken and with vegetables and either rice or potatoes.
Do you miss any of your insulin doses?
Well, if I don't eat breakfast, I don't do my insulin then. But otherwise, I do my dinner and before bed.
How about lunch?
Well, if I go out to lunch, I don't take it with me. I don't do it.
Okay. Any other questions before I examine you and see what's going on?
No.
All right. Okay. Before I kind of review maybe some of my thoughts and my takeaways here, we've got a poll that we'd like to get your guys' opinion. So how would this resonance feedback differ from direct observation versus indirect observation? Again, we have the pleasure of doing a direct obs on this patient. and this interaction today. So do you think the feedback would be the exact same? Do you think there would be more feedback maybe on medical knowledge, more feedback on communication skills, or less feedback on professionalism? I'll allow a couple seconds for you guys to submit a response on what you're thinking. We can kind of see the results here probably in another second or two. And so it looks like there is complete agreement that everyone voted there would be more feedback on communication skills. I agree with that. Sort of my takeaways when viewing this video, or what I observed with this interaction, is that there were a couple of yellow flags maybe about how the resident was communicating with the patient. It seems one of the main elements of the communication, there was maybe some poor eye contact throughout the interaction. There were a few times when the resident actually cut off the patient in the middle of a sentence, so didn't have great communication there. And there were a few moments when the patient was really expressing her frustration, and it doesn't seem that the resident went out of their way to sort of make sort of empathetic or sympathetic statements about, oh, that seems very hard. There wasn't a lot of rapport or trust building that seemed to be going on with this interaction. So when thinking about a direct obs and how to give feedback on areas for improvement, one of the elements for core outcomes would be for communication, maybe they required significant faculty assistance, or you observed that there are elements to improve here with this interaction. I don't even think that the resident did a great job of talking about the patient's chief complaint. It seemed that she had a differential in her head that she was pursuing, but again, the patient had to interrupt and say, you know, doc, I'm really feeling this way and it's intrusive on my life. So one of the competencies, the core competencies that this evaluation would map to would be something like interpersonal and communication skills, or patient-based communication. I think there's a couple more elements that we could evaluate here to another couple of core outcomes for this evaluation. The next being effective data gathering. As I was watching it, it seemed that the resident was gathering some relevant information. As an observer, I could see that she was thinking about diagnoses, for example, like congestive heart failure, or maybe a medication side effect. And she was asking those medically appropriate questions to assess for that, but didn't seem to get into much of like a review of systems, or had lots of open-ended questions. They were very close-ended questions, yes, no kind of questions, and maybe could do a little bit better in her data gathering. If a resident had come to present this to their attending, they might have a very, very appropriate differential that they're thinking of. They might have presented in a way that didn't really give any interaction to or any indication of how they got that data in the first place, or how appropriate their questions were. So indirect observation wouldn't really lend itself to having a good idea of how this interaction played out. So direct obs, again, is a great assessment for what actually happened. How did the resident come to gather this information? Were they on the right track with their differential? And so another feedback here for effective data gathering, mapping to a core competency with more interpersonal and communication skills. And then the final, maybe a third core outcome that would be relevant to this patient interaction would be in regards to time management. I think the resident maybe at the initial point did not set a great agenda. The patient had come in with their acute concern of leg swelling, and the resident sounded like they really wanted to address some of the chronic conditions that the patient had, and did spend a good amount of time talking about, for example, the patient's chronic conditions with their diabetes. And it seems maybe did not set an agenda for what the patient should expect. You know, hey, we will definitely talk about that, and towards the end of the appointment, I'd like to make sure that we address this. It seems that the resident was interrupting the patient, maybe because they felt like they had a lot to tackle in the appointment, and then didn't really sort of redirect the patient. The patient was like, hey, look, I really, really want to talk about how this is bothering me in my life. And the resident seemed a little bit dismissive. Oh, that's just age. And so I think there were elements for time management that could definitely be improved. So again, this might be a feedback of, required significant faculty assistance, and then the narrative comment, writing all those elements that you directly observed for improvement. For example, how this feedback would map onto a core competency, this would reflect back perhaps on like professionalism, where you're being conscientious of your patient and setting an agenda, or maybe patient-centered care and sort of navigating the system with this patient and their priorities and your priorities and meeting somewhere in the middle. So that's another element of feedback I think that I had observed with this interaction. So we use what's observed in the core outcomes in a direct obs. We think about how they relate to core competencies. In this interaction, the things that I observed, and other observers might take different elements from each interaction, but what I thought here to focus on is, providing comprehensive, excellent, relationships with your patient, care of chronic disease, and just sort of routine practice management. Developing effective communication and constructive relationships with patients was something that I think was relevant to this encounter. And then assessing priorities of care for the individual patient, and sort of balancing the preferences of what the patient wants to talk to with maybe what your medical priorities are for the appointment. And we're just kind of reviewing these three with this direct obs. So the whole purpose of direct obs is that we get this very valuable feedback and we work to improve it. For our program, we do ILP creation about every 12 weeks with a review in the middle every 6 weeks. And the ILP purpose is that we identify these areas for growth that we've now seen hopefully longitudinally with multiple data points from direct obs of saying, you know what, I do really think that this is an area for growth that your advisor will help you identify, that you will hopefully self-reflect and identify as well. And then working to find a very realistic implementable plan to improve. So for example, if you were this resident and you had this interaction with this direct observation, let's say that you want to improve with agenda setting. I want to create an agenda with my patient to make sure that they feel heard, but that I've accomplished what I need to with this appointment. So I'll set an agenda every time I walk in the room, make sure I address the patient's chief complaints, and then spend a moment saying, and I'd really like to address your hypertension at this visit and ensure that we have that well controlled. So the core outcome here is, again, we're making sure that our ILP does relate to that core outcome of assessing priorities of care for an individual patient. And with your ILP, you are, of course, creating your very realistic, implementable, measurable, time-sensitive goal. And I think that using the direct obs for this situation can help with that. I will, over the next 6 weeks, when you give me more direct obs, I want to make sure that every time I walk in the room, I have an agenda set, I acknowledge the patient's chief complaint. And that is something that is very measurable and strategic for helping this resident improve. So I'll kind of review final thoughts of this webinar to give you guys something to chew on and sort of consider as you move back into the orbit of your day, just sort of rediscussing the big thoughts today. This is new for everyone. Direct obs is something new, and there's always going to be growing pains with something new. I think that there are a lot of benefits to direct obs, but it was never going to be perfect from the second we said go. So embrace that, things are going to need to be improved. And really your feedback is critical to helping us improve. That's kind of the whole theory of direct observation, right? So take that theory of just as we residents need feedback to improve, a process like this that's getting implemented also needs feedback to improve. So your voice matters as a resident. I wouldn't be sitting here talking with you today if I didn't think your voice mattered as a resident. That's what I'm trying to do, is provide my perspective to hopefully make this process really implementable and valuable for everyone. You can always relay your feedback to your faculty. This will be relayed to STFM to hopefully, incorporate that real change that we want to see as residents. It's helpful with this process to be reflective. Self-reflection is a key tenet to getting feedback like this. If you are not able to sort of reflect on what can I do to improve with all these data points and this feedback, we need residents to buy in and really realize, you know what, I do need to improve in this area to become the best physician that I can be. So always keep in mind of what can I do to improve and how can I incorporate this feedback. Plan ahead. An hour of planning saves you 10 hours of doing. Hopefully you're not actually spending an hour prepping for your direct obs every day. Hopefully it's more like 5 to 10 minutes of planning for your direct obs is going to save you an hour or two in the long run. But for me, at least, I know that I still have to prep my patients every day before I come into clinic. And so spending an extra 5 minutes knowing what my ILP goals are, what my core competencies that I need to improve, and identifying, you know what, I think this would be valuable to address in this patient visit, or maybe I'll have a little extra time with this patient so I know I can incorporate that direct observation time more easily. That can be really helpful in the long run for implementing this process and helping you feel like it's really valuable. Don't be afraid to ask your faculty to help you maybe identify patients or times that would be best to work on implementing direct obs. For us, at least, there are certain clinics in which us third years have a little bit longer appointments, or there is a lower faculty to student ratio in which we're not vying for time as much as during a regular clinic. And so, for example, discussing with your advisor, with your faculty, saying, I think it's easier for me to implement my direct obs at this clinic or during these times. Make sure that you have your faculty involved in getting these direct obs, and that can also help the process go a little smoother. And then finally, we're all residents. We're here to learn. We're here to improve. Feedback like this can be really meaningful in helping us become a credit to the profession and a credit to, becoming the best doctors that we can be. So use this feedback to progress your own career goals, and then making sure that you're on track to graduate as a resident, as a wonderful doctor that I know everyone will be. Those are kind of the big thoughts that I wanted to leave y'all with. So I think we have a couple minutes dedicated to your questions so that we can, type them up in there and we can address those too.
So it looks like we already have one question. So the question is, do you have a sense of how often a resident is getting directly observed? It sounds like at this program, senior residents may only get it done in a couple clinics a year. And so really one of the goals of the current pilot program, a good benchmark that's been set is about 1 direct observation per resident per week. And that really is kind of gets to the goal of all of this, of getting more data points to see those trends across time. And so hopefully as senior residents move along, they're getting more of that clinic time. And so there's more opportunities to be able to find a time to get one of those observations completed. Hopefully 1 per week is a general goal that we've kind of set as a good benchmark.
And if I may, Maggie, I think what our program has done to really ensure that residents are aware of how much they've gotten and how much they need to do, we actually have like a large printout sort of Excel sheet in our resident room that tracks by week if you've had an observation that week. We actually have a sticker chart because we like stickers. And so we have a sticker in each week where we know we've had a direct observation, and faculty in their clinic or in their clinic room, they have their own Excel spreadsheet of when they actually did an observation for a patient. So in our own clinic room and when we're staffing with faculty, we have that printout right in front of us to say, oh, looks like I've missed it for the last 2 weeks. Let's work on getting a few this week.
Perfect. And then the next question we have is what type of direct observation is being used, in person, video, or a couple of examples given. And I would say for the most part, it sounds like programs tend to be doing this in person. It seems to kind of integrate well with maybe those Medicare or Medicaid visits that have to be staffed with an attending in person anyway, or those PGY1 visits that have to be staffed. And so the goal is to if it's done in person, it seems to be less of kind of a time burden than having to review videos after the fact. So I would say most of what I have heard is that this has been doing in person, but certainly I know some programs, my own has previously been doing like GoPro video cameras that we bring in and we do kind of have a meeting that we review those patient encounters with faculty. So I think that takes a little bit more time to get done and so isn't as able to be done maybe weekly, but certainly can be helpful for a deeper dive into some of this direct observation feedback. And then there was just a comment here that we can kind of share with the group, sharing that sometimes it may be helpful for residents to directly observe faculty. So, somewhat like shadowing, but it can kind of provide some experience for the residents to see exactly what they're looking for or what's being evaluated of them during direct observation. It can kind of share or see what tips and tricks that the faculty are actually implementing in their day-to-day life as a practitioner. So, could be a unique take on this process of getting some more buy-in from your residents of exactly what is being asked of them, kind of doing that vice versa as well.
And for example, one of the residents in our clinic, one of the third years, had faculty present for a direct observation while she was doing a shoulder exam. And she got some other tips and tricks that she hadn't previously known about how that faculty would have completed the shoulder exam. And I think that was helpful for her, which might not have happened had this been in direct observation and they had not watched her do the shoulder exam. So sometimes having faculty present for elements of the history or physical exam can be really supportive for, broadening our own skills.
Perfect. And then our next question is, do you use behavioral faculty in these observations? And I think this is program dependent, but I do think that this is a really great opportunity for your behavioral faculty to get involved, particularly if they're core faculty or engaged in residency education already. For example, with my program, when we would do the GoPro video review, that session would be completed, that review would be done with our psychologist and one of our medical faculty as well. So you're really getting that feedback from the medical knowledge side of things, but then also getting some unique viewpoints on how maybe a psychologist would handle tough conversations or navigating patient concerns. And so I do think that there's benefit from that situation. It may not be something that's easy to implement on a weekly basis if we're trying to get that once a week observation, but trying to fit that in every so often can be really beneficial for just an alternative viewpoint of tips and tricks to add into kind of your building of patient rapport. Okay, well, we'll give it one more second to see if any other questions pop up. But hopefully you have found this session helpful as we kind of walk through what direct obs looks like in practice. I know both Jen and I are excited from both sides, the faculty and the resident side, to kind of see this continue to build and grow. And there's definitely learning opportunities on both ends. So we're eager to hear feedback as this continues to roll out. And if we've got no other questions, thank you all so much for joining us today and for watching the recording. We appreciate your time.
Thank you all.